Okay, this out of the way, and make sure this is there. Make sure that goes away, and we're good.
Okay, cool. Okay, I think we're in business now that security let us in. So this is going to be an interactive presentation. So if you guys can get out your smartphones, and if you go to your browser and put in menti.com and that presentation code, it's going to bring up questions that we'll go through as we go through the presentation. And it will show up on the other slide questions too if you don't catch the number this time around, but I'll leave that for a couple of minutes or seconds so that you can get set up. All right, so the objectives today, today's lecture is on pneumonia. Today we are going to talk about how to triage which patients with pneumonia require admission to the hospital and who requires admission to the ICU. Know when to order diagnostic studies for the microbiologic diagnosis of pneumonia, and then how to select empiric therapy for community-acquired pneumonia and hospital-acquired pneumonia. The bulk of the talk is really going to be focused on number 3. So we're going to start off with a case. This is KF. She's a 78-year-old woman with COPD. She's not on home oxygen, and hypertension, who was admitted in March for unbearable right upper quadrant stabbing pain, 8 out of 10 radiating to her back. The pain is worse with coughing, which seems to be at her baseline. There's been no change in sputum quality or quantity from baseline. She's a smoker and lives with her grandsons, who are in their teens and early 20s. Her father had TB. Her vital signs are listed there. Pertinent findings on physical exam. She has decreased breath sounds, right greater than left, but no crackles, and there's egophony at the right base. She does have some right upper quadrant tenderness and pain in her right flank with no rebound or guarding. White blood cell count is 15.2. Her sodium's 131, BUN 29, creatinine 1.25, and her glucose is 236. She does have known diabetes. And her ABG is shown there, and that was done on 2 liters of nasal cannula with a pH of 7.34, a PCO2 of 34, and an O2 of 103. This is her chest x-ray. And it was read as infiltrate on the right side and a possible right pleural effusion. And she had a CT scan in part to further evaluate the abdominal pain, and at the base of her right lung there was lobar consolidation. All right, so the first question is, does this patient need to be admitted to the hospital for treatment of her pneumonia? I'm going to give you about 20 seconds to vote. And your choices are no, admit to the regular medical floor, or admit to the ICU. And for those who walked in late, if you go to your phone's browser and put that website in and then use the code listed, it will take you to the presentation. All right, about 10 more seconds. All right, so most people want to admit her to the regular medical floor, and about a fourth of people say nope, she can just be treated as an outpatient. So when deciding where to triage someone with pneumonia, there are several methods that can be used as a guide. The 2 most commonly used scores are the Curve 65, which is a severity of illness score, or a prognostic model such as the Pneumonia Severity Index, or PSI. And both of those can be used to identify patients with community-acquired pneumonia who might be candidates for outpatient treatment. As with any score, it should always be supplemented with a physician determination of subjective factors, including the ability to safely and reliably take oral medicines and the patient's outpatient support. So the Pneumonia Severity Index is a prognostic score. It's not as widely used as the CURB-65 because it's pretty hard to remember just off the top of your head. You can find the score on MD-Calc or Google other websites that will allow you to calculate the score. It's based on the patient's age and gender, their comorbidities, some of the physical exam findings, and lab findings. Some of which are routine and some that may not be available. Not everyone gets an ABG, for instance, in the emergency room. And based on the score, the PSI stratifies patients into 5 risk groups based on the total amount of points that they have. Risk classes 1, 2, and 3 have a pretty low risk of mortality with pneumonia, and outpatient treatment should be considered, especially if the patient is in class 1 or 2. If the score is greater than 91, then patients should be hospitalized for treatment of the pneumonia because the mortality rate is higher. So if we look at the case patient, she gets 68 points for her age. She doesn't have many of the comorbidities that buy her points. She did have an arterial pH that was below the cutoff, and she gets 30 points for that. So her total amount of points is 98, which would put her into class 4, recommended for hospitalization. So the other index that can be used to look at the severity of pneumonia is abbreviated the CURB-65. These are criteria from the British Thoracic Society, and it uses some clinical traits and lab traits to put patients into mortality classes as well. You get 1 point each for being confused compared to baseline, a point for uremia, which is a BUN greater than or equal to 19, a point for respiratory rate greater than 30, a point for low systolic or diastolic blood pressure, and then a point if you're over the age of 65. If the CURB-65 score is 0 or 1, the mortality is low and they can be considered for outpatient care. If they're 2, that's kind of in the middle, and they're on the borderline inpatient versus observation. And then greater than 3, you should consider inpatient admission, and if the patient has 4 or 5, then consider ICU admission. So back to our first case, she was not confused. She did meet the uremia criteria and the age criteria. So her score would be 2, which places her appropriate for either admission or observation, but probably not to be treated as an outpatient. So when should you admit to the ICU? When pneumonia is severe. There are criteria in the community-acquired pneumonia guidelines. The major criteria are pretty straightforward. If they're on the ventilator or on vasopressors, they should be in the ICU. That's common sense. And then severe community-acquired pneumonia can also mean meeting at least 3 of these minor criteria that are listed. And it's based on the respiratory rate, what their x-ray may look like, some of the same things that are included in the CURB-65 score, like confusion and uremia, and then leukopenia, thrombocytopenia, hypothermia, or hypotension, not requiring pressors. All right, so we're going to move on to another case of BG. She's a 65-year-old woman with congestive heart failure, coronary artery disease, diabetes, end-stage renal disease, sleep apnea, and a history of remote breast cancer that's been fully treated, who presented in late December with 1 week of cough productive of white sputum. She didn't have any fevers at home and didn't really feel shortness of breath or chest pain, but did have a lot of muscle aches. No sick contacts. She goes to hemodialysis 3 times per week and hasn't missed any of her dialysis sessions. On admission to the ED, her vital signs are as listed. She was mildly febrile at 38.2 and was satting 100% on 2 liters of oxygen. She had diffuse rhonchi bilaterally. Both of her graft sites, the old and the new, were unremarkable. White blood cell count was 5.8. Platelets were 77. BUN of 16, creatinine of 5.5. Remember, she's on dialysis. And her ABG on room air is listed as below. This is her chest x-ray. And you can see that maybe she has an infiltrate in this left lower lobe here. I calculated her PSI and curb 65 for you. Should she be admitted to the hospital? I'll give you about 20 seconds here. All right, 5 seconds. All right, so most people want to admit her again. Some want to admit her to the ICU, and then 17% say nope, she'll be okay at home. So you'll notice in this case there's a discordance between her curb 65 and her PSI score. So let's assume that we admit her to the hospital. What diagnostic studies do you want to order? And you can pick more than one if you want to. All right, 10 seconds. Okay, lots of votes for sputum culture, some for blood cultures. I agree with no bronchoscopy at this point. Maybe it's a little early. I think all of these other things are on the table. All right, so as we mentioned, her PSI score and her curb 65 were discordant. So what are some reasons that you might admit someone that had a low PSI score or a curb 65 score? If you were worried about the complications of pneumonia itself, like a lung abscess or a pleural effusion, if they have a lot of comorbidities and they had an exacerbation of one of those underlying diseases like COPD or CHF, if you're concerned about the reliability of the patient to take oral medicines or receive outpatient care, like they're homeless, or they've had a history of non-adherence to therapy in the past. If they have multiple risk factors that are just above or just below the thresholds for calculating the score, and they're really on the borderline, that would be a reason to consider admission. And then if there's any other medical or psychosocial needs requiring hospitalization, they're not able to keep down PO, they have injection drug use, psychiatric problems, or cognitive dysfunction. So in this lady, even though her curb 65 score was only 1, her PSI was high, and she had a lot of comorbidities. So I think it's reasonable to admit her to the hospital, at least for a day or two, to make sure that she's going to do okay. I think in this case, the curb 65 may have underestimated the severity of her pneumonia. So when to do diagnostic testing for etiology? It's not always needed, especially if you're going to treat someone in the outpatient setting for an uncomplicated pneumonia. The primary reason for testing is if you think the results will change the antibiotic management of a patient, that you think you might want to increase the number of antibiotics they're on, or if you're worried about unusual pathogens such as TB, non-tuberculous mycobacteria, endemic fungi, if they have a parrot at home and you're worried about psittacosis. It may also be important for public health reasons. If you're worried about Legionnaire's disease, SARS, avian influenza, or agents of bioterrorism, you definitely want to document that so that the public health agencies can be informed and address the issue. It's not common that it does allow de-escalation of therapy, but it can in certain cases where you do identify a pathogen. Let's say you isolate influenza on the respiratory viral panel, then you may decide that you don't want to treat for bacterial causes, keeping in mind, though, that there are instances of co-infection. So there are certain indications where we definitely want to do more extensive testing. If the patient's admitted to the ICU, you're going to want to do blood cultures, sputum cultures, a Legionella urine test, the pneumococcal urine antigen test, an RVP, and if they're intubated, an endotracheal tube aspirate. The pneumococcal urine test, the benefits of that over sputum culture is it does stay positive longer than the sputum culture will. So if the patient has been on antibiotics for a day or two before you're able to get the sputum, which often happens in the hospital, you may still be able to get a positive on the pneumococcal antigen. The sputum culture, in whatever case that you're sending it off in, is subject to quality. So if you don't have a good quality sputum culture, it's not going to be as useful. If there's a lot of saliva in there, if there's a lot of squamous epithelial cells, the lab will tell you how good the sputum specimen is. If it's just saliva, they're not even going to process it. But if there's a lot of squames in there, you'll be able to tell and take it with a grain of salt. Other situations where you might consider more extensive testing, if they failed outpatient therapy, if there's cavitary infiltrates on the x-ray, leukopenia or active alcohol abuse makes people more susceptible to encapsulated organisms and pneumococcus. And then if they have severe liver disease or COPD, asplenia, travel or pleural effusion, those are instances where you would consider doing more extensive testing. BG was admitted to the regular medical floor and have blood culture, sputum culture, and a respiratory viral culture are pending. And now I would like to know, what antibiotics do you want to start pending the outcome of your diagnostic studies? Your choices are ceftriaxone and azithromycin, ceftriaxone, azithromycin, and oseltamivir, cefepime and azithromycin, cefepime and cipro, ampsulbactam, or piptazo and vancomycin. Give you 10 more seconds. All right. I guess I forgot to put percentages on this one, but it looks like most people are going with ceftriaxone and azithromycin. A few people want to throw in some viral coverage, and then 5 people went with the old standby vancomycin. So her RVP did come back positive for influenza A, and she, I think, ended up being treated for both community-acquired pneumonia and influenza. So the most common etiologies of community-acquired pneumonia are strep pneumo, mycoplasma, Haemophilus influenza, chlamydophila, and the respiratory viruses. Strep pneumo is the easiest to cultivate. We think of the other ones as being the quote-unquote atypical pathogens because they're difficult to grow in the lab and more difficult to diagnose. In the ICU setting, the spectrum of etiologies is a little bit different. There's more severe cases of community-acquired pneumonia that end up in the ICU. So Legionella is more likely in this situation, as well as aspiration pneumonia. The other pathogens are similar between ICU and non-ICU. So let's go back to the case, and I want to make a few changes in her history and presentation. In addition to having all of the comorbidities that she had before and being on hemodialysis, she also has a past CT showing significant bronchiectasis now. She's also looking a little more sick than she did before. Her heart rate is 128. She's hypotensive. Not really oriented, and her white count is 14.2. So now we decide to admit her to the ICU, and she has a bunch of workup pending, and pretend we don't know that she had influenza. So now, what antibiotics do you want to start now, pending the outcome of your diagnostic studies? She's a little sicker now. She's in the ICU. 10 seconds. All right, before I show the results, let's kind of walk through what the differences are between these choices. So we know that ceftriaxone and azithromycin is the usual coverage for community-acquired pneumonia. And we talked about oseltamivir adding coverage for influenza. What's the difference with cefepime and azithromycin? What does that add? What are you covering there that you're not covering with ceftriaxone? Yes. What about cefepime plus Cipro? You're getting a little bit aspiration coverage, although there's no no anaerobic coverage here. It's double coverage for Pseudomonas, as well as coverage for atypical pathogens with the Cipro. How about Amp-Sulbactam? I think I heard someone say aspiration over there. So you're losing your Pseudomonas coverage with this, but gaining anaerobic coverage. Amp-Sulbactam does not cover the atypical pathogens. And then vancomycin. Yeah, MRSA, anaerobes, and we also have Pseudomonas coverage with that. All right, so lots of people went with piptazo and vancomycin, and a few others with some of the other answers. So cefepime and Cipro is what's recommended by the guidelines, actually, and by the Metro guidelines, which I'll show you in a minute. So we already talked about some of the most common etiologies of CAP in the ICU. And we are more worried about gram-negatives in this situation, and Legionella, as we suspected before. So what are the instances where you're going to be worried about Pseudomonas, and pick one of the coverages that did have Pseudomonas? We use single coverage if the patient's had IV antibiotics in the past 90 days, a previous respiratory infection or colonization with Pseudomonas, if there's significant structural lung disease, including bronchiectasis and cystic fibrosis, and all instances of hospital-acquired pneumonia and ventilator-acquired pneumonia. We provide double coverage for Pseudomonas in the situations that are listed here. If they're on the vent or have septic shock, HAP or VAP with IV therapy in the past 90 days, ARDS, 5 or more days of hospitalization, renal replacement therapy prior to VAP, or significant structural disease in the ICU. So because she had the bronchiectasis, we would put her on double Pseudomonas coverage until we got cultures back with susceptibilities. The reason for double coverage of Pseudomonas isn't because it's necessarily a worse pathogen, but there's so much resistance that you want to make sure you have at least one drug up front that's going to cover the Pseudomonas. So once you get a culture back that shows susceptibilities, if it is susceptible, you can back off of that. For Pseudomonas and MRSA, sputum culture is pretty sensitive for this, and if you don't isolate those pathogens, then you don't have to necessarily cover them going forward. This would be a situation where I would get a tracheal aspirate or a sputum in order to guide that therapy down the line. All right, our next case is a 29-year-old with congenital cardiomyopathy and an ICD who was admitted to telemetry in April of that year. She had cough and abdominal pain. The cough started 2 days prior to admission, and she took guafenicin and albuterol with some relief. She had some shortness of breath, mainly with coughing. Her edema is at baseline, and she didn't really think she had any heart failure exacerbation symptoms, and she hasn't had any fevers at home. Her vital signs are pretty unremarkable, but she did have some diffuse wheezing on the right side, and a chest CT showed a new infiltrate on the right side. So she reports she has an allergy to amoxicillin, which caused her hives at age 8. So which antibiotics do you want to start empirically on her? And if you want to review the history, 29-year-old, congenital cardiomyopathy, pretty stable vital signs, but wheezing and infiltrate. She's not been in the hospital recently. Bless you. All right, 10 seconds. All right, lots of votes for moxifloxacin. Some people still want to give her ceftriaxone and azithromycin. A few people picked meropenem, and then aztreonam, zinc, and azithromycin, staying away from all of those beta-lactams. So ceftriaxone and azithromycin is appropriate for this patient, and we will talk about why. Oh, we didn't do question 7 yet, sorry. So now her allergy to amoxicillin caused her difficulty in breathing. Does anyone want to change what they want to do? Before it was just hives, now she says she has trouble breathing. Ten seconds. All right, so now more people are staying away from the ceftriaxone and azithromycin, and most are going with moxifloxacin, and that is what is recommended by our guidelines. So when you're confronted with a patient with penicillin allergy, you first need to ask the patient what happens when they get penicillin. Sometimes people don't know. They say, oh, I got it as a child, and I was told never to take it again. Those are probably not real, but it's hard to say for sure. Mild allergies are those that don't have any features of an IgE-mediated reaction. If they just got a rash or isolated mild hives, if they report something like nausea or stomach upset, that's not really a true allergy. It's more of an intolerance. And in that case, it's probably safe to use penicillin as well. IgE-mediated reactions are more serious. This would be things like anaphylaxis, angioedema, wheezing, laryngeal edema, hypotension, widespread hives, but no mucosal lesions, skin desquamation or organ involvement. And then serious delayed reactions are things like Stevens-Johnson syndrome, TEN, drug-induced liver injury, or DRESS, hemolytic anemia, cytopenia, serum sickness, or interstitial nephritis. Those are all considered to be serious penicillin allergies. If they just have a mild allergy, it's reasonable to use cephalosporins or carbapenems. The cross-reactivity between a penicillin allergy and those other drugs is small. If they have an IgE-mediated reaction, you want to avoid the penicillins and cephalosporins, but it's reasonable to use carbapenems. But if they have a serious delayed reaction, you want to stay away from everything that's in the beta-lactam or monolactam class, all penicillin, cephalosporins, and carbapenems. So in the first case, when she just reported a mild allergy, you can go ahead and give her the usual ceftriaxone and azithromycin. But in the second case, when it changed to having difficulty breathing, then you want to avoid those agents. So for people, these are the Metro recommendations for people who have non-ICU community-acquired pneumonia, both with no penicillin allergy, a mild allergy, a moderate penicillin allergy, and a serious penicillin allergy. The difference is with the mild penicillin allergy, then we still use cephalosporins. If they have an IgE-mediated penicillin allergy, then the fluoroquinolones are playing more of a role, as are meropenem. We also decide upon the recommended regimen by what the risk for Pseudomonas and aspiration is, and the recommendations change depending on your assessment of that based on the criteria that we talked about before. In cases where there is significant structural lung disease, the bronchiectasis or cystic fibrosis, then Cipro would replace azithromycin in the instances where you have a choice. For ICU community-acquired pneumonia, the only difference is that ertapenem replaces the clindamycin plus Cipro for aspiration risk. And we also give a lot of the beta-lactams by extended infusion per the ICU protocol. You don't have to remember all of these. There is a pneumonia order set that walks you through each of these scenarios. Once you figure out where the patient is going to be triaged to and you determine whether you need to cover for Pseudomonas or aspiration, the order set will walk you through what the recommendations are. And they also have all the definitions for when you need to suspect Pseudomonas, what are each of these kinds of allergies. So it's a good resource both for management and for education. So our next case is a 56-year-old woman with COPD. She's on 2.5 liters of oxygen at baseline. She had a colon cancer that was resected 6 years ago. And she has 1 week of worsened headaches, dyspnea, and body aches. She also has a cough productive of yellow sputum. She was hospitalized 30 days ago for a COPD exacerbation and was treated with oral azithromycin and prednisone with improvement. 2 years ago, she grew MRSA from her sputum. On physical exam, her temperature is 38, heart rate is 125, blood pressure 130/80. She has bilateral expiratory wheezing diffusely and has a prolonged expiratory phase. White count is 23.5 with 16% bands, and her BMP levels are there. This is her chest X-ray. She has an infiltrate on the right side and possibly a small right pleural effusion on the lateral. So I bet you can guess the question now. What empiric antibiotic regimen do you want to start? Your choices again are ceftriaxone and azithromycin, moxi and vancomycin, cefepime and vancomycin, and piptazo and vancomycin. While you guys are voting, we'll kind of go through the differences in these again. Once again, this is your basic coverage for community-acquired pneumonia. Switching to moxifloxacin and vancomycin adds some MRSA coverage if you choose to cover her for that. Cefepime and vancomycin covers both Pseudomonas and MRSA, but you lose your atypical coverage. And then piptazo and vancomycin, we're covering for aspiration, we're covering for Pseudomonas, we're covering for MRSA. So think about what you're worried about based on the presentation that I gave you. And I'll give you 10 seconds. All right, so we have moxifloxacin and vancomycin as the leader, but almost an equal number want to give her cefepime and vancomycin as well. And I think we'll talk through which things we would be worried about. So she has COPD, and she was recently hospitalized. I think this is on the next slide, so I'm not going to say it here. And she also grew MRSA, so that's something else we would consider to cover in her. So I think for a lot of you who might have picked vancomycin or cefepime-based things, the old guidelines used to have hospital or healthcare-associated pneumonia. And if patients were an inpatient in the last or had an inpatient admission of greater than 2 nights in the past 90 days, or were a resident of a nursing facility, we treated them more like a hospital-acquired pneumonia. In 2016, though, they updated the guidelines, and we don't have HCAP anymore. They did further studies that showed that the microbiology of patients that fell into this category was really more similar to community-acquired pneumonia patients. And so those patients are treated more like community-acquired rather than healthcare-associated pneumonia. So now we just have community-acquired pneumonia and then HAP or VAP. Hospital-acquired pneumonia is pneumonia that was not incubating at the time of hospital admission and occurs 48 hours or more after admission. And then VAP, or ventilator-associated pneumonia, develops at least 48 hours after initiation of mechanical ventilation or a tracheostomy. Both HAP and VAP, we need to include coverage for Pseudomonas plus or minus MRSA based on risk. So the patient that I just showed you doesn't have hospital-acquired pneumonia. We would treat her for community-acquired pneumonia, and then probably with the addition of vancomycin for MRSA coverage. So I would have given her either ceftriaxone, azithromycin, and vancomycin, or moxi plus vancomycin. So we already talked about when to suspect or cover Pseudomonas. To remind you, it's if they have previous respiratory infection colonization with Pseudomonas, if there's significant structural lung disease, any patient that has hospital-acquired pneumonia or ventilator-associated pneumonia, and then if they've had renal replacement therapy prior to the onset of their ventilator-associated pneumonia. So when do we suspect or cover MRSA? If there's cavitary pneumonia on the chest x-ray, if they have a severe pneumonia, either CAP or HAP, and had a recent influenza-like illness prior to their severe pneumonia, MRSA is the most common cause of post-influenza pneumonia. If there's been previous MRSA respiratory infection, if they've had IV antibiotics in the last 90 days, or any HAP or VAP patients in the ICU. If it's hospital-acquired pneumonia and they're not in the ICU, then you don't need to cover MRSA off the bat. But I would get a sputum sample in those patients to help guide therapy. So for hospital-acquired pneumonia and ventilator-associated pneumonia, culture microbiologic data become even more important than in community-acquired pneumonia. MDROs are very common, and empiric therapy needs to be guided by the local antibiogram and then modified based on the results of your testing. So your empiric testing may include Pseudomonas and MRSA, but getting the culture back may show that they have a carbapenem-producing KPC or Club Pneumo, and you have to modify therapy to broaden it to include that coverage. Non-invasive respiratory cultures, whether it's an endotracheal tube aspiration or a tracheal aspirate or just a sputum culture, should be used to help guide this therapy. So this is a 56-year-old woman who was admitted 5 days ago for stage 4 non-small cell lung cancer. It was just a routine admission for chemotherapy. She received the chemotherapy, but is now having worsening cough and production of yellow sputum, worse than her baseline. She's also short of breath and has new oxygen needs. She's allergic to penicillin, which caused hives 40 years ago. Her physical exam is notable for the need for 5 liters of oxygen by nasal cannula, and she has decreased breath sounds on the right. Her white count is 8.4, and she is anemic and thrombocytopenic from her chemotherapy. This is the chest x-ray. She has a little bit of increase in her lung cancer findings, but compared to 2 months ago here and this admission, she has a more dense infiltrate on the right side. So, best empiric regimen. So we have someone who has been in the hospital for more than 5 days, hives to penicillin, and we don't have any microbiologic data for her now. Your choices are cefepime, meropenem, aztreonam and vancomycin, and piptazo and vancomycin. Give you 10 seconds. Oh. So most people picked piptazo and vancomycin. I think there's 2 possible choices here. Cefepime or meropenem wouldn't be wrong. We try to limit the use of meropenem in the hospital. Because she's not in the ICU, we don't need the extra MRSA coverage that's provided by piptazo and vancomycin. Cefepime or meropenem would be adequate in her situation. So these are the recommendations for antibiotic coverage in the non-ICU setting for hospital-acquired pneumonia. As we mentioned before, Pseudomonas coverage is indicated for all hospital-acquired pneumonias. MRSA coverage only in the ICU. Do you need that? So her penicillin allergy was hives, which is considered a mild penicillin allergy. So the recommended drug is cefepime. If you are also worried about aspiration, then meropenem might be an option. And like I said, it isn't wrong to use meropenem, but we like to reserve it only for cases where we absolutely need it. The other situation where you would use meropenem is if her penicillin allergy were severe. In all these situations, we would add Cipro for double coverage of Pseudomonas if the patient met those criteria for double coverage that I showed you earlier, which are also in the pneumonia order set. For coverage of HAP or VAP in the ICU, we do add MRSA coverage. In cases where we're worried about aspiration, the recommended regimen is piptazo and vanc. If it's no aspiration, cefepime plus vanc. And then those are the regimens for penicillin allergy. So to sum it up, there are tools available for use in conjunction with your clinical judgment to determine the most appropriate site for care for community-acquired pneumonia. If you're treating the patient as an outpatient, you may not need to do diagnostic studies, but they should be considered for severe community-acquired pneumonia and ordered for all cases of HAP or VAP. Also, in any case where you're suspecting an unusual pathogen, I forgot to mention, if you are worried about something like mycoplasma or chlamydophila, those can be diagnosed two ways. Some of them are on the respiratory viral panel, but the other way is to do acute and convalescent serologies, one during the hospital and then one on follow-up. You can only really make the diagnosis retrospectively if you're relying on serologies. The guidelines for empiric therapy for CAP and VAP depend on the location of admission and the severity of disease, as well as the presence of risk factors for Pseudomonas, MRSA, or aspiration, and whether the patient has a penicillin allergy. And as I've mentioned several times, the empiric treatment recommendations can be found in the pneumonia order set in EPIC, which has just been updated by Dr. Hecker, and a lot of other people worked on that too. So I had some practice cases, but I think we are out of time. So I'll stop there and take any questions. Mm-hmm.
Sometimes you get patients with COPD or fibrosis. They don't have clinical features that don't exist, but their biggest CT scan shows some specific changes. Do you come to the one in that context?
Not for just COPD. If they don't have if they had pulmonary fibrosis or interstitial lung disease, I might, but for plain COPD, not. No Pseudomonas. You could go back and look at them to see if they had any other lung disease. Oh, if they had bronchiectasis, then yes. I think I'd use clinical judgment based on how sick the patient was. If they were on the floor, you can probably try not covering Pseudomonas. If they're intubated in the ICU, that's a different story, and I'd be a little more aggressive in that situation. And it also depends. There's different levels of bronchiectasis as well. All right. I guess that's it.
Thank you.
Thank you. I have.
Oh, you're going to do it?
I figured it was going to take a long time.
I blame security.
We can do that. All right.
Because